Foundation and NGO, Chairman of BCM International Medical Academy, Academic Platform of Trivandrum Medical College Alumni, Director, Global Antibody Liver Clinic. Apart from the past position of Vice Principal and Head of Department of Gastroenterology, Trivandrum Medical College, the Dean, University of Kerala, Professor of Hepatology of SRMC, Chennai, MTA Coordinator for the Royal College, London, Coordinator MRCP Training Program in Medical College, Trivandrum, Chairman Draft Committee for Cadaver Transplantation, Kerala, Chairman Transplant Authorization Committee, Chief of Examiner DNB Theory of Southern States from 2009 to 2015, Chairman State Medical Board, Examiner for DNB and DM Gastro, PSC, UPSC, MRCP, and MTA of Royal College. So that means so many positions he has held and contributed to chapters in various textbooks. So you have a great person, a great teacher, a great examiner with a vast experience. And I have great pleasure in welcoming Professor Vinay Kumar to deliver that talk, which is mainly exam oriented. That is the importance of physical examination in day-to-day practice as well as in the examination. Over to Professor Vinay Kumar. And before that, I welcome Professor Jayanti, who will be co-chairing with me. Hi, Professor Jayanti, good evening. And okay, you will be co-chairing with us. Welcome, Professor Jayanti. Over to Professor Vinay Kumar.
Hi, dear Professor Varghese Thomas. Dear Professor Jayanti.
Good evening, sir.
Good evening.
Nice to see you.
Yeah. My dear colleagues, dear residents and friends. So thank you very much for the invite, And at the outset, thank you, Professor Varghese Thomas, for your kind words of introduction. And I appreciate the initiative of ISD and the support of Sun Pharmaceuticals for this sort of platform for the DNB students. And I also appreciate the initiatives of Professor Varghese Thomas. I was with the Professor Jayanti, and then to conduct these clinics for the DNB students. And I'm really appreciative of the good effort. And this sort of training program is actually going across and is very useful for the DNB students. I have some experience with them, madam. Thank you for your, Then I myself thought, why don't we have this sort of training platform for DNB students in Kerala also, because we have a large number. So I think thanks for the initiative. Shanai sir, thanks, sir. Welcome, sir. Thanks. Shanai sir. So I think, I'll share my screen now. So I think
you can see, sir. Yeah.
Okay. Yeah. So I think I assigned the task of discussing with you the clinical methodology, and the time will be probably 1 hour, and I'll be making my presentation for about 40 minutes, and then we can have the discussion. And the clinical methodology, the classical one, in fact, is starts with the history taking. And we know the different components of history taking and the clinical examination. And then we come to a sort of differential diagnosis, and based upon the based upon the differential diagnosis, you start investigations. Well, I think, now there is a lot of the investigations available for us, and then we need to discuss more of these investigations, and you need to know how to interpret these investigations. And then, of course, we have to go for management and including the prognosis and prevention. So I think that's the classical format of the clinical approach. And I'll be taking you through the clinical examination part, which in fact has got 3 components of general examination, systemic examination, and the examination of the relevant systems. So I think, we need to take a call, again, whether this is whether we need to change this clinical approach, with the current time, whether we should modify that, it's not a decision which we can take here in India or in Kerala, because, we have global standards, and then we should be listening to the opinion of other people also. But of course, we can give our opinion. This is the I have given four the practices which I see right now among the different consultants. The first approach will be that going through the reference letter first, before the history and the examination. It was not actually permitted before. The Puritans, they will be keeping aside this reference letter, and then they used to go for their own history taking unbiased. And then they go for examination, they make the diagnosis, and then only they will go to the reference letter. So is it the correct method? Or can you just go to the reference letter and then go for these, it's not a bias, but in fact it's a help. So is it that way? The second pattern is that, there's no history and no examination. Just take the patient to a procedure. So you will be, when we are actually practicing your super specialty, many times, the patients are referred to you for a particular procedure. So I think you just apply with that particular procedure. No history, no examination. Okay, so that is another thing which I come across. The third, in fact, is, you order for a panel of blood tests before the patient is seen by the doctor. So the doctor sees the patient only with the panel of investigations, and then they go for a short history and examination. That is in some of the corporate setup, And then a short history followed by relevant investigation, including imaging and physical examination, probably is actually pushed the last part. So I think these are different types of practices which I find among my senior colleagues, reputed colleagues. So I think based upon that, I'm just giving this thought whether we need to change the clinical approach. Whatever is that, the clinical methodology should be taught correctly. So if you are actually teaching this way, you have to follow that. There should not be any ambiguity. So that's my suggestion. It's not just for the examination, clinical approach and methodology. It's the same you have to practice it, all the time. Whenever you see the patient, all throughout your life and your practice, you need to follow that. That means that the examination should be honest, realistic, flexible, practical, and therefore customized. So I think that is the key word which I'm going to stress all throughout my discussion, in this evening. So we'll take a call towards the end, from our senior consultants, colleagues, whether we should have to change the clinical methodology based upon the probably situation which are different nowadays. So I think now, before going to the task, then I will just give this story to you. This is in fact about 2 years back, when I was the head in the Department of Gastrointestinal at Trivandrum Medical College. This patient, in fact, was referred to me. He is actually a 35-year-old male. He is referred from Kanjirapalli Government Hospital with history that he is HbA positive. He's not having any symptom. However, there's a background. His brother died due to HCC recently, and he was HbA positive. And he had another brother who died of jaundice and ascites 7 years back, and he used to take alcohol. We don't have the actual medical history, but then it's also a cirrhosis later, probably could be HCC also. So I think with this background, the patient, in fact, is referred. The patient was seen by one of my residents, is HbA positive, E antigen is negative, AST, ALT is only mildly deranged, his DNA level is not that much, so it's not very high. Ultrasound scan shows mild hepatomegaly, and the spleen is 10 centimeters. There's no portal vein thrombosis, no space occupying lesion of ascites. So the resident said, he's got a chronic HbA infection, he's HbE negative infection, or the so-called inactive carriers, we used to address these people as before. And therefore, he suggested no antivirals for the patient. And he said you require only a follow-up with the LFT and ultrasound scan probably after about LFT after 3 months, you can have a review. So that was the opinion of the resident, But then with this, the patient came to me and said that, he was seen by the resident, but then he's not satisfied. I thought, I saw the case summary of the resident also, which I have given to you. So I thought everything went well. So any of you feel that residents, what is wrong here? Do you feel everything was okay? Everything was okay?
Anybody can volunteer.
Yeah. Well, I called the resident, and I told the patient that everything appears to be okay, Probably you don't need any medicine or investigation right now. Probably you can come with your LFT after 3 months and then we can have a relook. But then the patient said that, sir, I came from Kanjirapalli, but then I was not examined. The patient said, oh, then I thought, well, it is not correct. So I said, well, I will examine you. Well, I started examining briefly a general examination, and then I went for the abdominal examination, and then I had a scare. I asked my resident to check the abdomen, and then he nearly collapsed because he had a hard liver, enlarged heart irregular liver. Okay, so to make the story short, the patient died in about 2 months' time, and this patient would not have. Suppose the patient was actually sent back, but the advice to come back after 3 months, that probably he would not have come back. So I think with this story, then well, I will discuss this clinical examination with you. Yeah, always you should have a proper history. You need to orient for the exam. It's not just starting your examination, embarking upon the examination suddenly. It's not that way. There should be a history to orient you. Okay, and then with that, you need to have a general examination, systemic examination, and other relevant system examination. Better to keep that sequential order. You start with your general exam to get oriented, and then you do general examination and the systemic examination, and then go for the relevant examination in that particular order. You can always combine. I know, because when you start your history, you start your examination. That's true. But then to begin with, you do the sequential order. I used to enjoy the bedsides with MD students and MBBS students also. And once I was taking a bedside with the MBBS students. And then he has given the person here, he has given a brief history. And I thought it was really brief for the occasion. But then I did not actually make any comment because they are the MBBS students. And then the general examination. You know what this is? What is in here? What is in here? Well, then he said that, sir, general examination, there is no pickle. Okay, so then I heard, I just asked him, what pickle? Then he was actually staring at me, this man is going to teach us, but he does not even know what pickle, So I think the residents pickle. Yeah,
Pallor, icterus, cyanosis, clubbing.
Yeah, so this is what he meant, pallor, icterus, clubbing, cyanosis, lymphadenopathy, and edema. Okay, so I think, probably with the needs and all, you are actually used to acronyms, So he said, it's very convenient for him, sir. General examination, there is no picket. Okay, so I think the systemic examination, but this is my comment, on the 3 parts of the examination. Systemic examination is easy. You do the abdominal examination very well. The cardiologist, cardiology examination, and the pulmonary respiratory examination. That part is okay for, many of the students, But general examination is difficult. It definitely is not pickled. You need to go beyond the pickle, Okay. And the examination of relevant system, I found that, the residents have no idea at all. Even during the public examination, I find that, they do not know how to do the examination of the relevant system. So I think I will just spend some time with you for the general examination of the relevant system later. I would like to do it on a face-to-face basis, probably after the corona. I can take up that assignment. My general examination is difficult, because I told you it's a highly customized. It's not just picked. It's to be highly customized, and you need to complete within about 2 to 5 minutes time. And you don't have a long gap, So based upon whether you are seeing the patient as a long case or short case, that's what you get for that. So you need to get properly oriented, and there's a lot of things to cover also. So I think now I'll share you to prove my point. I'll share some of the cases, which I have seen. So this, in fact, is a case, a patient, who came to me about 2 months back. This is a 72-year-old female. She's a retired teacher. She's a cancer survivor. She had ovarian cancer 2 years ago, and for which a total hysterectomy was done, and she was completed chemotherapy also. Now her problem for about a week back, it was chest discomfort and heartburn. So ECG was normal, and hence the patient was sent to a gastro department, where an endoscopy was done. We showed gastric erosions, and an ultrasound scan got gallstones, but there's no evidence of any cholecystitis there. She was put on proton inhibitors and prokinetics. But the problem is that, she did not find any relief. And not only that, she had a sudden exacerbation one day, after a few days, both the belching, palpitation, and anxiety. And this time she was taken to a cardiologist. She was admitted. Serial ECGs were normal, and the property was negative. And then the cardiologist referred the patient to me for a second opinion. So that's how the patient landed with me. So what could be the differential diagnosis, this is what I thought, again, cardiac causes, I'm very much, concerned about the cardiac causes, I can think about that,
Residents, Deepak is there? Deepak Bank?
Yes, sir.
Yes, sir.
Answer Professor Vinayama's question. Differential diagnosis in a case of intractable.
In this particular case,
emergency causes, cardiac causes we have to rule out. Second, pancreatitis will be the possibility. And third is a GERD. And
okay, so we got some response here. Thank you very much, Deepak, for that, for that participation, So I think the cardiac causes, I'm always, concerned about that. Many times, we burn our fingers also. So I think this time also, as the first differential, I consider cardiac causes, ischemic heart disease, again, I considered. And then pneumothorax, something which we need to consider. And all these, above the diaphragm. And mediastinitis, Now with the CT scan, we pick up some cases of mediastinitis. Previously, we did not used to. I can tell you a story, about probably 20 years back. Then we used to do sclerotherapy. I had a lady, I have done a sclerotherapy, and after about a week, she presented with severe chest pain. Her chest X-ray was normal, but then she continued her chest pain, and I asked for a CT scan, and I found that she had got a collection in the mediastinum, and the surgeon has strained 2.5 liters of pus. Mind you, the chest X-ray was normal. So mediastinal abscess, then procedures can be make diagnosis, And an esophageal ulcer, foreign body, especially if it is actually fishbone, which is stuck, very, very easy to miss, in one endoscopy. So I kept this differential diagnosis, and then I started examining. I found that, the patient was very anxious and sweating. He had a mild tachycardia. She was a hypertensive, but then the BP was really okay. And the patient was not anemic, but the patient has got leg edema, bilateral leg edema. So I think, yeah. So what is your differential now? This patient has got the bilateral leg edema. Anybody?
Dr. Deepak, do you want to also?
so then point out to the cardiac causes.
Yeah, cardiac causes. Yeah. Anything? Anybody else other than Deepak? Yeah.
Dr. Mithun, Dr. Bhargava.
Okay, so I think well, you have to be very quick, So yeah, so I'll give the answer. I thought, yeah. So I thought, but this patient is a cancer survivor of ovarian cancer, and then she had chemotherapy. So I thought I would just look at the inguinal lymph nodes. So when I was trying to look for the inguinal lymph nodes, generally we see the patient's legs below the knee, Well, but then I wanted to look at the inguinal lymph nodes. So I had a more exposure. And when I exposed the legs more, this is what I found. Any differential right now? Well, I think, I found that, leg edema is not actually below knee. The edema is extending above the knee as well. And there is actually an asymmetry. It is not symmetrical. There's really an asymmetry. And this asymmetry is more evident above the knee. Agree with that? And so what would be your differential right now?
Anybody?
DVT of the pelvic veins.
Yeah, DVT. DVT you need to look into. I think what is the test for DVT, DVT. Yeah, what next? DVT. Yeah. So I think, Homan sign, or this is generally when you become a specialist, you tend to forget, your medicine days. Homan sign. Well, for those people, who are not able to remember, anybody you can volunteer that, Homan sign? You should be able to.
Tenderness on compression of the calf muscles.
Yeah, so you have to dorsiflex, give a jerk, to the angle, dorsiflex, and then there will be the pain, the calf. Okay, so this is not very sensitive, but then that is the sign. So I think, you need to do this Homan sign right now here, and here the Homan sign was positive. Okay, and then how will you correlate here? So do you know the importance of the leg edema below knee and above knee? Anybody? Below knee and above knee. Yeah. Below knee and above knee. Below knee, in the case of DVT, the pulmonary embolism risk is less. Or rather, the reverse I will emphasize, If you have got a thrombosis, of the deep vein above the knee, the chance of pulmonary embolism is very high. And you need to put the patient on this warfarins or anticoagulants. Is this point okay? Below knee and above knee, okay. So I think something above knee, the risk of pulmonary embolism is very high compared to below knee, significantly high. Okay, so because of that, I thought this patient has got pulmonary embolism. Because at this point, I thought the patient, I made the diagnosis of pulmonary embolism. Okay, and then this is the CT scan which shows a thrombosis or embolus there, which is not very acute. And the cardiologist felt that, he can be managed with enoxaparin, and there is no surgical intervention required, it's only unilateral. So this patient is on enoxaparin. The patient has no worsening, and gradually the patient is improving, and the opportunity the patient studied the day before the study also, the patient has no problem right now. So I think what the learning point here, the general examination is not a predetermined script. Okay, when you find a trail, you need to follow that and explore. That's why I emphasize that it is not pickled. It's not a predetermined script. And that's why it makes it very interesting, general exam interesting, and but it's difficult also to some extent. Well, I will take you to another case, I think which probably you'll be more familiar with this particular case. It's a 35-year-old female. This is an ulcerative colitis patient on azathioprine and mesalamine for 4 years, and now presented with an exacerbation of 8 to 10 bloody stools a day, and there is no history of drug default. Okay, and so what could be the diagnosis like? The severe colitis may be due to?
Dr. Karthik Reddy.
Refractory.
Yeah, but the patient was actually responding that they are, yeah.
CMV colitis could be the cause.
Yeah. So I think, well, sir, thank you very much. There may be an acute ulcerative colitis exacerbation, maybe a refractory. You're correct. And maybe a cross-and difficile infection or CMV colitis, and the management could be different in all of these situations, Okay. And on general examination, this is what you find. Okay, what do you find here? Anybody answering that? Anybody?
Erythema nodosum.
Pardon?
Erythema nodosum.
Yeah, erythema nodosum is a correct answer. This is an erythema nodosum. Okay, this is a classical erythema nodosum. I think, do you find the cases of erythema nodosum with ulcerative colitis in your patients? You feel that, because of the dark skin and etc., you don't find. But then if you carefully look for that, but you do find. I find cases, of erythema nodosum. Okay, this it's a classical case, where you find erythema nodosum, this reddish, peanut-like and firm in the subcutaneous nodules. And this is a classical location also just above the medial malleolus. There's no problem. And the importance is that, it indicates exacerbation of the ulcerative colitis. So in this particular patient, it would mean that it could be, exacerbation and may not be because of CP colitis. I just rightly said, refractoriness is accepted. Okay, but then you can find in other sites also, like extensor aspect of the forearm you may find, and over the elbow you may find, and sometimes over the back also in the interscapular region you may find. So the classical description, it'll be okay to you, easy to make diagnosis. Sometimes it may be larger. Erythema nodosum could be larger, and it can extend more proximally. And then you probably could be in dilemma, as in this particular patient. Or sometimes, you can even ulcerate. Okay? And then it may be difficult. It can pose challenges in making differential diagnosis. What is the last one? The last picture, in fact, is it is not ulcerated erythema nodosum. It is pyoderma gangrenosum. Okay? So now you may think that, why should you distinguish a pyoderma gangrenosum from an erythema nodosum? It's crazy, you might think. But now I have given you the sequence, it might look like the same. Probably there are a lot of similarities, So, and the meaning is different. Some of these extraintestinal manifestations, they come with exacerbation, and some are not associated with exacerbation. Pyoderma is not, erythema nodosum is. If it is erythema nodosum, you can always wait, nothing active. Probably you can give a short course of steroids, that you give for the IBD exacerbation, and it will come down. But the pyoderma gangrenosum is a different diagnosis altogether, and you need to address it separately. So I think, for that you need biopsy. Okay, biopsy. What will you find in biopsy in erythema nodosum? What will you find in pyoderma gangrenosum? Anybody? Erythema nodosum pathology. Well, when I ask this question, mostly I get granulomatous inflammation. There is no granulomatous inflammation for neither for this erythema nodosum nor for pyoderma gangrenosum. Erythema nodosum is a paniculitis, basically inflammation of the adipose tissue. A pyoderma gangrenosum is a gangrene. You may find necrosis with plenty of neutrophilic infiltration and thrombosis of the vessels. But the biopsy is very important, because the outcome will be different. Okay. So the learning point here is that observation needs to be meaningfully interpreted and can solve clinical dilemma. Okay, I will take you to another case very quickly. Okay, so probably within about the next 10 minutes I'll be able to finish it. This case is an abdominal pain and exploratory laparotomy. I wonder, whether this such cases ever occur. I used to wonder. But then I find similar cases. 6 months back also, I have seen a similar patient, though laparotomy is something extreme. So this is a patient which I have seen 30 years back. So this is a 24-year-old female, and she presented 3 weeks after marriage, developed abdominal pain and hematemesis. She had taken non-steroidal anti-inflammatory drugs for knee pain. So I think what's the correlation? So probably honeymoon urethritis and a joint pain, Ritter syndrome, and NSAIDs may be given, so that may be the correlation. So endoscopy was done, shows extensive gastric erosions. The patient was given PPI and then DASES, but then the story is not ending there. 5 days later, the patient had severe abdominal pain And the surgeon felt, at the peripheral hospital, the patient had cavity. And then Amelia's life is normal, and he has, gone for exploratory laparotomy. And the note suggested that, there's no bowel gangrene, no perforation, but congestion edema at the small bowel. I think it is abdomen was closed, but the pain continued. Okay, so that is the situation, and the patient is referred. Okay, so I think this is the lower limbs. You can see that the right, knee is swollen, is a bit, you can see the redness over that also. So, anybody diagnosis?
Vanilla, Dheeraj,
Any diagnosis right now?
Hemarthrosis.
Pardon?
Hemarthrosis.
Yeah, hemarthrosis.
Someone has
But
answered.
I think there should be a. No, I told you, you need to. This is a general examination. It's not a systemic examination of the knee. This is a general examination of a patient who had laparotomy for severe abdominal pain, negative laparotomy or congestive bowels, still continuing to have abdominal pain. So a hemarthrosis is not acceptable here. So
we have an answer, gonococcal.
yeah, so I think, this, now you have the diagnosis. What you see like this, yeah.
Online purpura.
Yeah, now this is, it's a very easy answer, Yeah. I think, I don't know whether it was there, at the time of laparotomy, and if you see this, probably you can save a laparotomy. So I think the point is that, henotional purpura is painful purpura, is palpable purpura. But I want you to understand that this is proximal purpura. Proximal in the sense that, more distributed in the proximal region, or rather sometimes, to your embarrassment, it'll be confined to the proximal region. You'll be finding the purpura proximally only in the posterior thigh or in the buttocks, embarrassing the buttocks, as in this particular patient. If you do not find a similar clinical picture where it is confined to the posterior aspect of the leg, proximal part, but you are missing lesions. Because, I continue to see patients, 6 months or so back, I have seen a patient. The diagnosis purpura, it was missed by other people. It was seen by other people, and because it missed it because this is seen only in the proximal thigh. And the learning point here is that you need to extend the general examination based upon the clinical clues. Okay, generally you look at the lower limbs below the knee, but then you need to make your differential diagnosis, based upon which you have to do the general examination. Then only you'll be able to examine the posterior thigh. Okay, so probably I can share one more case very quickly with you, and then I can wind up. So this is a 55-year-old male non-alcoholic patient. And this is a story of a CLD listed for transplantation. Yeah. This patient is a decompensated cirrhosis patient and is listed for transplantation, did LDLT, and etiology is idiopathic, negative for the viral screen. Autoimmune markers and the usual workup were actually negative for this patient. And the LDLT did not actually materialize because the son was the donor. He is less than 20 years, and then he was afraid and he became reluctant. So, the LDLT did not actually materialize. So this patient, they came for supportive measures, He came with severe ascites and massive leg edema for supportive therapy. He had severe pallor. Okay, and but this is the tongue, Yeah, your diagnosis. Your diagnosis here.
Anyone? Bhargava?
Yeah. So, so I think you have to make this diagnosis now because the diagnosis.
We have a diagnosis, hereditary hemorrhagic telangiectasia.
Telangiectasia is the diagnosis because you have to make this diagnosis because, even now, this diagnosis is clinical. It's not by investigation. And you should know the Shaolin criteria, where you find this family history because it's autosomal dominant. You will find the telangiectasia in many parts. You need to look for other parts also. And there should be history of bleeding on different sides. And there should be evidence of systemic involvement also. If you find 2 out of 4, well, you call it hereditary hemorrhagic telangiectasia. And even now, it's a clinical diagnosis. You can't investigate for this. Okay, so you need to know that, And so this patient had a enlarged liver with arterial bruit, and this but the question is, can it be associated with cirrhosis, chronic liver disease, hereditary hemorrhagic telangiectasia? Can it be associated with liver disease?
Yes.
Yes is the answer. Yeah. So I think you should have the clinical knowledge that way. Yes is the answer. Definitely, yes is the answer. Can be associated, Yeah. So this patient had endoscopy, small varix only, but multiple telangiectasias in the stomach, And the previous reports actually mentioned that these as severe PHG and severe GAVE. So he had multiple telangiectasias in the colon also. The patient improved with the multiple blood transfusions, and the gastric and colonic telangiectasias were addressed with organ plasma coagulation. With that, the patient had drastic improvement, and the MELD came down to less than 15. I came down to 11 or 10, and the patient became all right. He had probably he was all right for about 3 years then. And then he had a recurrence of anemia after 3 years, The capsule endoscopy at that time showed extensive telangiectasia of the small bowel, and he became transfusion dependent, And he had survived for 5 years and he succumbed. So I think here the learning point is that the mouth and tongue will be an important part of general examination, and you need to have a toast with you. I think now I find that the people are actually using the facilities in your mobile, but then I find that it is not sufficiently focused on the posterior pharynx and all. So I prefer a conventional torch even now. So you need to examine again, even if the patient is coming from a higher center. So I think my previous story was that of a patient referred from the local hospital, but this patient is coming from a higher center. So you need to examine properly, even if the patient is coming from a higher center. So I think with that, I will come to the last part of my talk. And again, it could be a repetition because I want to drive home these points, Get a brief history, how to do the general examination. Get a brief history. I think before that, before doing the examination part, you should have a brief history, and you should formulate differential diagnosis and get properly oriented. And then you should have an enumeration in your mind what to look for. So I think it's very important, And then how to look for, you should know. You should be very confident about the methodology, how you should, each should be looked for in its own way. And when a relevant observation is made, and then you need to follow the trail. But it should be a dynamic process, So the general examination, it should be creative, and it has to be dynamic. And so this is a dilemma of the students, how to present the observation in a general examination. So this is my suggestion, First present those findings, which you have anticipated based upon your differential diagnosis. For example, a patient with ascites, Well, those findings is you mentioned that your patient has got the paralysis, patient has got the jaundice, this patient has gynecomastia, etc. And then those observations, though not anticipated, but you find some observations which can be correlated, to modify differential diagnosis. You find an operative scar on the left forearm. It's an accident, Well, probably multiple transfusions, etc. FRICE, so that way you may be able to correlate. So that will come next. And then mention those observations which you expected, but you did not find. For example, say in this particular patient, probably there is no leg edema or no spiral tumor that way. And then mention any observations, well, even if the relevance of which is not very clear to you, some obvious observation will be there. That also need to be present. For example, if the patient has got, in this particular patient, if he has got an artificial eye or a polydactyly or something like that, So you need to mention that also. So I think that's the way you have to present it. And a few words about the common mistakes, not properly oriented with a good history. I think there's a commonest one. You'll be reduced to just a third year pickle, So, well, even for DM and DNP, we find that, the general examination, in fact, is reduced to pickle, and you miss a lot of points and diagnosis. So, wrong methodology, improper position. For instance, for the patient, well, you will be asked a form and sign. Okay, so there will be an improper methodology. And I find that, even examination of the tongue, but people make mistakes, So, and then a back and forth examination, non-meticulous inspection, without any definite purpose. You just, again, reduce to pickle, Serious omissions will be there. For example, you don't check the blood pressure, Don't examine the mouth and tongue, sometimes, because the clue may be there, as in the case which I have shown you. And not examine the fundus in relevant cases, So such serious omissions could be there. And then finally, lack of skill and knowledge for a critical observation, interpretation, understanding. I'm telling you again and again, general exam is more difficult than the systemic examination. And definitely you get more clues for a correct diagnosis in general examination. So with that, I will wind up, and then I will leave you this take-home messages in the form of 5 principles, One is to be customized. Again, I'm emphasizing, it's not one size for all. The examination of each patient is different. And make a differential diagnosis in mind before you start your examination. Principle 2, there should be a sequence, There should be a head-to-foot examination or a hand-to-head-to-foot. And there's no back and forth examination. You should be confident that I've covered that. And after examining the foot, I just forgot about that. And I going back to the face. So that back and forth examination is not good because that shows that you are not confident about it. Your methodology is not correct. You're not confident about your methodology. And keep on looking for a trail for further observation. It's very important, it's very important. And take a note of these Sherlock Holmes, after Conan Doyle, in fact, he was a doctor. Principle 5 is take a note of anything unusual and then try to understand its significance later. Or probably this significance will come later, when you discuss with somebody else. So with that, I stop here and I will take up questions and I would like to hear the comments of my colleagues, especially, that we should be able to change the pattern of clinical approach.
Thank you, Professor Vinayama. That was a fantastic lecture, and I enjoyed every bit of it. I'm sure our students and other faculty got that. I feel it should have been little more. That your lecture should have been little bit more. Okay, next time I think we'll have more cases and we'll give an opportunity to come back sooner so that we'll cover more cases. And our examination seems to be in OSCE mode, especially for DNB students. Yeah. And these sort of short cases and description will be extremely useful to them. Yeah. I now invite Professor Jayanti for special comments and any other additional points to be made, and also request other faculty members who are attending also please chip in with your great inputs. And I request the students, residents, to put in your queries in the chat box, and I will read it out, and Professor Vinay Kumar also can look at the chat box and answer their queries. So now over to Professor Jayanti.
Good evening, sir, and wonderful session. Enjoyed it. Always, when I listen to your clinical talks, it is always, I always remember not the virtual one, the live ones. And every time we used to see you examining here during your short stay at SRMC, I recall those days and the gym sessions which were conducted in Kerala.
Thank you very much, madam.
Wonderful.
My associations with you.
Yeah, and I think what you started with the first slide, I think that is most important. And I do keep telling my students, even when you get a referral from a person, from a doctor, I always say, give respect to the doctor who's referred. I don't even read the reference because then you get a bias. Give respect because then you put it aside and then start taking the history. But as you rightly said, today it is opening the case sheet first and then going. Then there's a total bias. Then the mind does not work. And if the mind does not work, you do not see what is there in front of you, right in front of you. And I think it was a wonderful session. And I think probably, sir, you can just touch upon this JVP bit, This even in DND examination, they do ask How do you look for a JVP? And that is often missed. Number one. Number two is when you're taking a history and you find there's a jaundice as you see the patient does not come forth with that history. What should the candidates do? Should they take it up as a lead history or say that history-wise nothing is there, but on examination I found this? Then there's a total non-correlation between the history and the findings of the examination. So I have these two comments to make, sir.
Ma'am, you would like me to answer your second part,
Yes, sir.
Actually, yeah, when you find, say here, the examination is not in the OSCE model. So when you find the jaundice, after your history, you examine the patient and you find jaundice, you need to ask further about the jaundice. And then you have to incorporate that aspect also in the history.
Yeah.
Because history, I believe, is not just about the narration of what the patient is saying, but then your edited version of the patient's narrations. And if the patient is missing something, you need to ask leading questions when you find something, when you feel relevant, and that also needs to be included in the history. That only becomes a complete history.
Other thing was some of these skin lesions, most of us are dark pigmented. And I think quite often we're likely to miss the fair group. Yes, we can pick up these erythema nodosum. So is it likelihood that we're likely to miss some of these erythema nodosum and pyoderma? Yes, it's easy. Purpura, things like
yeah,
this.
I feel that we take it as an excuse for not examining the skin properly. Okay, so if you just look properly, you do find the skin lesions, and then if you just look at the eyes, you can see the pupil, and in a white person, you can very well see the pupil, but even in our own people, if you look carefully, you can definitely see the pupil. So I think the skin lesions are seen. Well, in the case of God is like a great artist, when Picasso or Rembrandt, they make their creation, painting, and they have the habit of signing, to the bottom. So you will be able to find that, So in the case of very difficult cases, well, the God will be actually signing it on your skin. So if you read that, you make the diagnosis, It is not in Hebrew and Sanskrit, It is in the form of a skin lesion, which you should know how to decipher, That means your clinical skill.
And recently also we had a patient, especially patient with tremors and all, they will try to withhold all the movement. Then we had a patient recently, Duplin's contracture, everything he tries to hold, So as you rightly said, unless and until we examine in detail, they're likely to miss the diagnosis. We had a patient in DNB examination. That's true. That particular patient just kept on folding his hands, and the tremors were actually missed.
Yeah.
So I think we should have an open perspective, and that's an art, sir. What you rightly said, that physical examination is an art. Yeah.
Yeah, it's not, the patient is not actually demonstrating the physical finding. You need to look for the physical finding. It's your job. It's not the patient's job.
Dr. Varghese?
Yeah, Shanai sir, are you there?
Dr. Katie is there. Yeah.
I am so thrilled to listen to Dr. Vinay Kumar.
Good evening, sir.
An extremely good evening, Dr. Jayanti. A very lucid presentation, which I think should be like a Bible for all of our DN and DNB students. I thoroughly enjoyed all the cases which my dear friend Dr. Vinay Kumar has put forward.
Thank you, sir.
And I wish that we should have more and more such sessions with the postgraduates. I find that they are not very active. I think Varghese Thomas has to call them again and again. Only two names like Karthik and Deepak, as if others are either in slumber or they don't listen. I think Dr. Varghese Thomas, probably you can make a list. I was trying to look at the participant list and try to find out some of them who are not willing to offer any comments. I think we should make a point to call them, because these sessions are meant for them. They are not meant for me, Dr. Vinay Kumar, Dr. Jayanti, or Dr. Varghese Thomas. I think Dr. Vinay Kumar has taken such a lot of pain to put all his scientific information which he has collected by his own observation over a 30-year period. I think I probably saw the case which Vinay Kumar mentioned as hemorrhagic telangiectasia. That patient also had come to me once for a APC. So many of these, like erythema nodosum versus the pyedoma gangrenosum, looking at the buttock for some of the skin changes. I think you have to really undress a person. So modesty prevents us from doing it. But I think time has come that these lesions cannot be detected by ultrasound or a CT scan. Only a physical